Welcome back, class, to the second part of the lecture set number 8, covering chapter 15 and 16. We'll continue with our discussion of chapter 15 material at this moment. Schizophrenia and other disorders. Schizophrenia is a psychological disorder characterized by delusions, hallucinations, disorganized speech, and/or diminished, inappropriate emotional expression. The word itself, split, is schizo, and mind is phrenia. Oftentimes, schizophrenia is confused with another disorder that we'll be discussing, dissociative identity disorder or multiple personality disorder. The idea, however, is that with schizo or split, it's not talking about split personalities per se. The split here is a separation from the person's reality, okay, their emotionality. So that's what is meant by the split or the schizo. Schizophrenia is the chief example of a psychotic disorder, which is marked by irrationality, distorted perceptions, and loss of contact with reality. With treatment and a supportive environment, over 40% of the people with schizophrenia will have periods of a year or more with normal life experience. But just 1 in 7 of those diagnosed will make a complete and enduring recovery. What patterns of perceiving, thinking, and feeling characterize schizophrenia? We have positive symptoms, meaning the presence of inappropriate behavior, and negative symptoms, meaning the absence of appropriate behavior. Disturbed perceptions, hallucinations, seeing, feeling, tasting, smelling things that exist only in the mind. Disorganized thinking and speech, for example, delusions. False beliefs. Here you may hallucinate there's somebody in the room with you and there's nobody. That is hallucination. It's totally in your mind. Whereas if you see somebody in the room and there is actually somebody there, but you believe the person to be someone else, that's a delusion. That's a false belief. Many of these individuals have paranoid tendencies. They also have what is known as word salad, where they have senseless speech or gibberish, and they break down in selective attention. They can't focus on things selectively in their intention environment. Diminished and inappropriate emotions. We can have flat affect, meaning an emotionless, a state of no apparent feeling whatsoever. They can have impaired theory of mind, difficulty reading other people's facial emotions and states of mind. You don't get it. You aren't able to connect with other people. You can't read their expressions. We also have emotional deficiencies, occur early in illness and have a genetic basis. Inappropriate motor behavior with motionless catatonia or senseless compulsive actions. So we also have chronic versus acute schizophrenia. Chronic schizophrenia, also called process schizophrenia, a form of schizophrenia in which symptoms usually appear by late adolescence or early adulthood. As people age, psychotic episodes last longer and recovery periods shorten. Acute schizophrenia, also called reactive schizophrenia, a form of schizophrenia that can begin at any age, frequently occurs in response to an emotionally traumatic event, and has extended recovery periods, often positive symptoms that respond to drug therapy. Now let's talk about dissociative disorders. What are dissociative disorders? They're very controversial. First, we have dissociative disorders. They are rare disorder in which conscious awareness becomes separated or disassociated from previous memories, thoughts, and feelings. So that's why we have the confusion between schizophrenia and dissociative identity. There is this idea of split or separation. So here you are being separated from previous memories, previous thoughts, or previous feelings. One of the common ones that we see portrayed quite a bit in movies and television shows is dissociative identity disorder, formerly called multiple personality disorder. It's a rare dissociative disorder in which a person exhibits 2 or more distinct and alternating personalities. So you have one body, but have at least two personalities in there. The personality of the original person who was born with that body and the personality they developed, and then an alternate personality that's also present within that body. And at times in stressful situations, the alternate personality may take over, driving the body, so to speak. That is what is a dissociative identity disorder or multiple personality disorder. Now, let's look a little bit more closely here, understanding what DID is. Well, there is quite a bit of controversy over this disorder for a variety of reasons. It's one of those types of disorders that are culturally bound, meaning that we normally see this type of disorder in certain types of cultures. For example, it is rarely found outside of North America. That's Canada, Mexico, and the United States. It increased dramatically in the late 20th century when people started to know about the disorder and promote it in a sense. Promote people saying this thing actually exists. And then more people started turning up having this disorder. DID may reflect role-playing by people who are vulnerable to therapists suggesting, meaning that they are role-playing the alternate personality. They're pretending to have a different personality than from their original personality. Some psychodynamic theorists view that this disorder as a manifestation of feelings of anxiety. Some learning theorists view this disorder as a response learned when behaviors are reinforced by anxiety reduction. So we pretend to be someone else personality-wise, and our anxiety is reduced because of it. So we're in a stressful situation, we sort of close our eyes to it, and then we pretend in a way to be someone else. Our anxiety is then reduced. Some clinicians include dissociative disorders under the umbrella of post-traumatic stress disorder, meaning that it's caused by some sort of stressful event, and this is their response to that stressful event, creating another alternate personality that is more capable and stronger, that they can deal with the stressor that's been placed in front of them. Now, some of the other disorders, we have personality disorders. Three clusters of personality disorders. We'll look at what behaviors and brain activity characterize the antisocial personality. So, personality disorders, inflexible, enduring behavior patterns that impair social functioning. Let's think about what this is basically saying. We've talked about personality before. Personality is that somewhat consistent way that we think, feel, and behave. It is to a large extent who we are. By saying a personality disorder, we're saying that this is an enduring behavior pattern of our emotionality, our thought process, and behavior that really has a significant impact on our life. So these disorders form three clusters characterized by anxiety, that predisposes to the withdrawn and avoidant personality disorder, eccentric or odd behaviors such as emotionless or disengagement, which is more relative to the schizotypal personality disorder, and the dramatic or impulsive behaviors as seen as borderline personality disorder, narcissistic personality disorder, and the antisocial personality disorder. So let's look at the antisocial personality disorder. You've probably heard of this before as well. A person with APD displays a lack of conscience for wrongdoing, even toward friends and family members. So think about this. They're in it for themselves. They really don't have empathy and care for other people. They may sometimes be very impulsive, fearless, and irresponsible. They do things because they want to do them, and they really don't concern themselves with who may be hurt for it. Sometimes we can see criminal behavior in a very similar way. In fact, sometimes people who are criminals and incarcerated somewhere, they may suffer from some form of personality disorder. But a true person who has an APD is going to be different than a lot of criminals. For example, a lot of criminals may be very dangerous characters and very violent, but they may not be so toward their friends and family members. But the key point here about someone suffering from APD, They lack of conscience and wrongdoing even toward friends and family members. So criminality is not an essential component of antisocial behavior, and many criminals do not fit the description of antisocial personality disorder, since they do show responsible concern for their friends and family members. Now, understanding the APD. There are biological relatives of people with antisocial and unemotional tendencies are at increased risk for antisocial behavior. Some specific genes identified as more common in those with APD. These genes also increase the risk of substance use disorder, and these disorders often appear in combination, the APD with a substance use disorder. They have low autonomic nervous system arousal in situations others would find unnerving. So when we see something very stressful, okay, we in our body responds to it. Our autonomic nervous system reacts to it. We feel the fear. Whereas someone who is suffering from APD, however, that same event occurs in front of them, they don't feel that fear. It doesn't bother them. So we see that these genetic predispositions may interact with the environment to produce the altered brain activity associated with antisocial personality disorder. Now, oftentimes we do see people who may have these antisocial behavioral tendencies. It does not necessarily mean they're serial killers or criminals. It just means they don't have the same type of emotionality and connection and empathy that we may have. Sometimes these individuals can be very, very effective in certain careers in which they may have to make decisions and hurt or harm a lot of people. Sign a document in the afternoon and then the next day tens of thousands of people lose their homes. Some people would not be able to deal with that, but some people who are a little bit disconnected from them emotionally may be able to manage it. Alright, some of the other disorders. You've heard of eating disorders like bulimia and anorexia nervosa. So with anorexia nervosa, a person, usually an adolescent female, but it can be males, usually an adolescent female, maintains a starvation diet despite being significantly underweight already. People with anorexia nervosa continue to diet and sometimes exercise excessively because they continually view themselves as being overweight, as being fat. Bulimia nervosa, and it should be noted, by the way, that this is one of those other disorders that is very much culturally specific, meaning that we normally see anorexia nervosa and bulimia nervosa only occur in societies that are really have wealth in food, meaning food is easily accessible, and there's usually a very large media entertainment component. Now, bulimia nervosa, a person alternates between binge eating, usually of high-calorie foods, with purging, actually vomiting, or laxative use, getting the food they've just eaten out of their body, sometimes followed by fasting or excessive exercise. These two individuals, the anorexia nervosa and the bulimia nervosa individuals, will appear quite different. When you see someone with anorexia nervosa, you know there's an issue. They're just way too skinny. You may even see the bones underneath their skin. However, the bulimia nervosa individual, they may be regular weight to maybe slightly above regular weight. So they appear relatively normal when it comes to their weight. But of course, continued use of this technique of vomiting or using laxatives can have a major impact on the system, particularly with the vomiting. One of the first things we see happen with the bulimic nervosa individual is the acid from the stomach from all the continual vomiting will start to rip away at the enamel of the teeth. The teeth will start to have an issue. We also have binge eating disorder, significant binge eating followed by distress, disgust, or guilt, but without the compensatory purging or fasting that marks bulimia nervosa. The American rates are 0.6% for anorexia, 1% for bulimia, and 2.8% for binge eating. So we see a lot more binge eating followed by bulimia, and the least that we normally would see, 0.6% of the population, is going to be anorexia. So let's understand these eating disorders a little bit. Family environment. for those diagnosed with anorexia is often competitive, high achieving, and very protective. Those with eating disorders often have low self-evaluations, set perfectionistic standards, and are intensely concerned with how others perceive them. Heredity. Disorders seen more in identical twins than in fraternal twins. Cultural pressures. Ideal body shapes versus vary across cultures and time. Some cultures in the world, they will not see someone who's particularly skinny as being attractive. But in many westernized cultures, skinny is better. Other influences are going to be low self-esteem and negative emotions interact with stressful experiences. Prevention programs have had success, especially effective when interactive and focused on girls over age 15. Now, let's look at therapy and treatment. So we've talked already about psychological disorders, and we've done a sort of a review of the different types of psychological disorders out there. Once you have a psychological disorder, you can choose not to seek treatment, or you could seek treatment. From the previous discussions, we know that if you don't seek treatment, we do see a lot of people will bounce back. But again, if treatment is sought, we normally see the recovery is going to be quicker and more long-lasting, less likelihood that you'll get that issue later. Forms of therapy and those in need of treatment. Many forms of therapy have been developed to treat a wide variety of problems. These Marines who served in Iraq and Afghanistan together with community mental health volunteers are part of an ocean therapy program at Camp Pendleton, a program in which learning to surf is combined with group discussions. The program helps vets recover, especially vets who suffer from PTSD. The percentage of adults who received mental health treatment in 2004 to 2008 is shown here. Adults seeking treatment increased slightly from 2004 to 2008. If we were able to look further back, we'd probably see a greater increase in treatment being sought compared to the 1960s or 70s. Later generations have become more open to the idea of seeking treatment for their psychological disorder. Children in treatment and past treatment. About 1/3 to 1/2 of U.S. adolescents aged 8 to 15 with mental disorders receive treatment, with behavior-related disorders more likely to be treated. We also want to look at the painting we have here. This painting, Goya painting, depicts the madhouse. It depicts a mental asylum and its inhabitants in the early 1800s. It portrays those with psychological disorders as victims. Now, treatment and reform and other factors. It should be noted, as we indicated in the previous session, that the early treatments of people who have psychological disorders were somewhat harsh at times. They may have been thought to be possessed, for example, or practicing some form of black magic. But the case is that it took some reformers to start to change these ideas. Dorothea Dix was a social reformer who became an advocate for the indigent, insane, and was instrumental in creating the first American mental asylum. She did this by relentlessly lobbying state legislators and Congress to set up the fund for such institutions. Now, this brought into a different age of trying to say, we are going to try to treat these individuals with these disorders, not just put them away. We're going to try to fix them, so to speak. So we've seen other things happen too. There are many institutions, mental institutions around the country, but then after several economic downturns, the government started to close these institutions down with the invention of different types of medicines that could be utilized to treat these individuals on an outpatient basis. Now, at one point, when they started closing these facilities down and releasing them, you would have the people maybe in halfway homes, but eventually, oftentimes, they would wind up becoming homeless. They would stop taking their medicine and go live on the streets. And this is what happens as well. Also, we see a lot of individuals who may have these disorders wind up as part of correctional institutions. They report a higher number of individuals living with mental illness there. The artifacts of treatment and types of therapy, they can be very, very varied. We have the type of therapy promoted by Sigmund Freud of patients laying down on the couch. We have therapy too where people can play in the sand or sand trays. There are many ways, as we saw previously with the Marines on the beach, there are many ways and forms and artifacts of treatment. So there are a lot of creative ways in which people can find some means to discuss the issues that they're dealing with or find ways to occupy their mind in a more constructive manner. Behavioral therapies is one that can be very, very beneficial. We saw in previous chapters when we talked about learning about classical conditioning and operant conditioning, they use those types of techniques employed in a way to help people deal with their psychological disorders. We have exposure therapy, seeks to change the response to a conditioned stimulus. And unconditioned stimulus is presented over and over just after the presentation of the conditioned stimulus. And we see here how exposure therapy can work here. The idea is that the rabbit causes fear in us, and we're going to try to break that fear response. This person on the side here suffers from arachnophobia, fear of spiders. Through exposure therapy, he is learning how to face his fear in a controlled and therapeutic setting. So there's going to be less and less fear present. Emotional responses to the event is a major thing that we saw previously when it comes to the vicious cycle that tends to lead to depression. It all is about when something happens, how do you establish the reasons behind that event, unfortunate event happening in one's life. So if you fail a test, does your assessment of what happened and why that happened, do you have the internal belief of saying, I'm worthless and stupid? Well, having and holding such beliefs lead to depression. Or you can have this, the internal belief, I'm smart, but I didn't study for the test and I can do better. That type of assessment as to why you failed that test does not lead to depression. And so what this is really pointing to is the idea of how it is that you attribute the reasons behind such failures. And you can be taught and trained through therapy to have more realistic and beneficial appraisals as to when something bad happens or unfortunate happens. How can you assess it in a way that does not lead to further issues of depression or guilt and things of that nature? So your emotional reactions are the result of your thoughts about the situation rather than the situation itself. So the situation happened, but how you see it will determine what happens to you later. We have a variety of different approaches to therapy. We have the one-on-one and group approaches. One-on-one has some benefit. It's undivided attention toward that particular patient or client and the therapist. But in a group, there can be some benefits too. You can see different perspectives. You can also work on social interaction and social phobia as well. And of course, in a group situation, it may be less costly for the patients to combine their sources to pay their therapist as opposed to paying for a one-on-one session. One other type of counseling is marriage counseling and couples counseling. A therapist helps people work on their relationships. One of the key ideas there is better communication and expectations. Age, drug use, and cost. Well, let's get down to it. The National Survey on Drug Use and Health shows trends in prevalence of various drugs for ages 12 to 17, 18 to 25, and 26 and older. So we can see here that for a lot of young people, that what drugs they seem to be employing more often. We have marijuana or illicit drugs. We see here cocaine or inhalants. Oftentimes it'll depend on the age group and what they have access to. Substance use and abuse costs the United States over $600 billion a year in a 2012 study. So the idea is that there is going to be a variety of issues when it comes to drug use and illicit drug use and the impact it has on our particular society. And finally, the idea that we need to understand too, as we go over the key points of this particular chapter, cultural and religious beliefs impact on mental health attitudes. How do your cultural and religious beliefs affect your attitude toward mental health treatment? These things need to be at least considered and thought about as one seeks therapy. So again, what we've talked about in this last session, we looked at the variety of types of psychological disorders out there that we have identified that are listed in the DSM-5 that list the symptomology, the course of the particular disorder, and how they may be treated and the research on them as well. And then we entered into a discussion about types of therapy and treatments. There are a whole variety of therapies out there. We did not go over the biomedical therapies that we see, a lot of use of drugs and things of that nature. But the idea with psychology is the notion that we want to understand not only our mental processes and our behavior, we want to understand how our mental processes and behaviors may not work effectively or efficiently in our day-to-day life, and figure out ways in order to address those particular issues. And that is what therapy and treatment is attempting to do.